today we're gonna learn about the preoperative and preoperative care in cardiac catheterization laboratory or cath lab. And before we start the lesson, so I would like to ask you something that you can see on this screenshot on this screen. That you can see that who can tell me what is the difference in these two pictures? Don't worry. There is is that enjoy with this question. There is no point at all.
The C arm, right, Ajahn? Because
ใช่
like the first one and the second one is different.
Yeah, the C arm is the different that show on the picture. The upper one is the single pan, right? And the lower one is the blind pan. So who can give me further information? What is the benefit? What is the benefit of the blind pan? I think all right, so I'm gonna tell you the benefit of the blind pan is because there is two C arm, right? So when the interventional cardiologist inject the contrast into the patient to examine the coronary artery, so the image that we generate it just use just a single time of the radio like X-ray beam generation. It just like I don't know hit on the bottom one time, so you will get two image. So in this case, it will reduce the contrast media using. When compared to the upper one, that is the single pan that normally the interventional cardiologist will acquire four image of cine or X-ray image in four pictures. But anyway, in case of biplan, so the doctor will require also four images as well. But anyway, or four views. But anyway, due to it's just a biplane, right? So when the doctor injects the contrast a single time, so we will get the two images, and it will use reduce the contrast using in the patient, and it can provide the benefit for the patient who have the kidney disease or some kind of that, like have the renal problems or renal failure, that contrast can induce the worsening of the disease like renal failure or chronic kidney disease in long term. All right, for the objective of this topic, I would like you to understand the principle and rationale of preoperative and perioperative care in cath lab. And I wish after you get the knowledge from this topic, I hope you be able to help or manage the patient in cath lab. And here is the image that I would like to show you about our roles in the cath lab, that our guest instructor like Ho Sin Chi from Thermo and also PTF from Bam Dong Lat also tell you or tell us about our main roles in the cath lab already, right? You can see that when we are the cardiovascular and thoracic technologists in cath lab, so we can do the three main roles. The first one is the scab node, right? As you can see. Oops, sorry. As you can see here. So the scab node is the position that will assist the interventional cardiologist for doing the procedure. And like PTF say yesterday, that we are the important one that can make the patient that can make the physician decision, like when a doctor or physician on the steroid field stick on some problem or stick on something, like don't have the consensus decision, so we can provide him the choices or some instruction or direction to him, like be a friend and also be the friends in the healthcare professional, something like that. And the second pictures, you will see that we also be the circular technician as well. The important thing that that circular technician need to do is just observe the screen and also observe the patient while the doctor doing the procedure. And the important thing about the circular technician is when there is the urgent situation exists to the patient or happen to the patient, like have the chest pain, or you see the hemodynamic monitor waveform on the screen has some problem, like VT or ventricular tachycardia or VF or ventricular fibrillation, something like that. So you have to warn the doctor and also the scrub nurse on field to see something wrong with the procedure or something wrong on the patients, and the doctor will find the solution or find the problems to solve that situation. So the circulate technician is also important role in the cath lab, especially in the procedural room, while the doctor and scrub nurse has to keep the sterile always, because they need to perform the procedure right. And the last one will show you about the our role as well as the hemodynamic monitor technician, that will control and also record every step of the procedure in computer, and also logbook sometime in some hospital. And the hemodynamic monitor technician is also important role in cath lab as well, because um, in this position we have to look on the monitor on the screen always to see the changing of patient hemodynamic or ECG, or arterial waveform or oxygen saturation, something like that. If they see some changings like slow heart rate or bradycardia, or VT, VF, or PVC, that we call that premature ventricular contraction, right? If you see something that can interrupt the procedure or make the worsening outcome to the patient while doing the procedure, you have to warn the doctor immediately. Like um, I'm not sure in Thai we can call อย่าง something like อาจารย์มีบางอย่างแบบ PVC ครับ PVC ค่ะ something like that, like อาจารย์there is PVC exists on the EKG, some kind of that. And the second part of being the hemodynamic technician is you have to record any step of the procedure, right? From the patient arrive into the room, right? At the preparation area or in the procedure room. So you have to record the time, and you have to record anything that exists or happen, or happen to the patient, or any drugs that the doctor give to the patient, or any equipment that the doctor give to the patient. So you have to record anything. It's just like the backup of the procedure when have something, like when it has something happen to the patient, like in the worst case that have some some a problem with the การฟ้องร้อง some kind of that. So we have the backup file, right? Then we have to use this in the court or something like that. So you can see that everyone in this room will work with each other like as a team, and you can see that the interventional cardiologist is the head or the leader of the team that will bring the team achieve the better outcome or provide the better outcome to the patient. So every single person in this room is very important, and is we will need each position, each is person in this room, and we need to work with each other to get the patient better. And when we look at the pre-operative care and perioperative care, so the thing that we can look on this things like the pre-operative and perioperative care, so we can categorize this caring regarding to or depending on the compartment in cath lab. Like when we look at the pre-operative care, so this caring that we need to take on the patient is begins at the on the patient arrive at the hospital or the OPD or something. If the patient have the appointment to doing the procedure, until the patient arrive in the procedural room and start doing the procedure. So this entire period we can account as the pre-operative care. In this carings, like in this thing, normally, generally the nurse will take care of the patients rather than us. Like it's not our main role that we have to take care of the patient, but we have to know about the step of pre-operative care, because and sometimes even we can directly take care to the patient, but we need to know what is the important thing of the patient, what is the a condition of the patient, what is the medication that the patient takes. So we need to know about this information, because we also work as a team, right? But anyway, I told you just one time that it's not our directly role to take the pre-operative care. And when the patient move into the procedural room, so when doctors start doing a procedure, after the end or finish the procedure, in this period we have to take care of the patient as well, and in this period we will call perioperative care. So in this in this period of caring, so we have to observe the patient or the sign of the patient or symptom of the patient by the doctor give like doing a procedure to the patients, like I say earlier. And of course, we're not the main position, or we're not out the main role that we have to take control to this caring on the patient. So the main role is comes to the nurse. But anyway, we have to know about the steps and also the information of the patient as well. So we have to help or assist other personnel in the room. And when we look about the principle and rationale of the pre-operative care, is about, the principle and rationale of the pre-operative care is to evaluate and plan on the procedure, right, based on the patient condition or patient information, especially appropriate prepare the patient before starting the procedure to prevent or reduce the risks or problem during the operation or during doctor doing the procedure, and eventually finally some kind of that. So I hope it will improve the post-operative outcome, or the get the better outcome to the patient. Anyway, the key point of the principle and rationale is just evaluate, plan, and prepare the patient before doing a procedure to get the better outcome. Here is the key point of the pre-operative care. And like I say in the previous slide, that the pre-operative care account as the patient arrive at the hospital, right, at the OPD, in case of elective, not account as the emergency case. After, when the patient arrive at the hospital, so the first thing that we need to do is just ask the patients about booking or the appointment card that will have some details about date of doing the procedure, and also disease, and also hospital number and also another information that physician or interventional cardiologist requires from the patient, something like that, to confirm the date and the operation that patient need to do on that day or in the tomorrow, something like that. And after that, we have to measure the vital sign of the patient, including weight and height of the patients as well, because we need to know about you know about how the blood pressure is, how good the pulse rate is, or respiratory rate is good or was, something like that. So we need to evaluate or examine the patient before doing the procedure. All right, so and the weight is really important as well because um, weight of the patient is necessary to use to calculate the heparin administration, right? Because in the procedure, like during the cath lab, the catheter or a thing that we need to, our doctor need to insert into the patient artery is the foreign bodies, right? And our body have the interactions or immune response to the foreign body, and it can cause, like release a lot of cytokine that can induce the clot or, blood clot formation. So we need to give the heparin to the patients to prevent the blood clotting. So in case of this, we will use the weight of the patient to calculate the heparin dose. And when we look at the last one on this slide is about history talking. In Thai, we call sak pawat. I'm not sure about this. I think it's just like sak pawat. So nurse will do a history taking, right? So the information that we need to gain or we need to obtain from the patient is about chief complaint. It's just like what's event that take the patient to the hospital. In case of this, so the patient have the appointment, right, for doing the procedure. So in case of this, the like appointment date will be the chief complaint of the patient, like having the procedure. But in some time, if the patient gets sick or doesn't feel better, like suffer with some disease, and when patient arrive to the hospital at first time and would like to see the doctor, so when the nurse asks about history taking or do the history tracking, the chief complaint of the patient at that moment is just like a symptom of the patient that bring the patient to the hospital. It counts as the chief complaint. And the second one is the present illness. It's just like a current symptom, a medication or investigation or treatment that the patient currently get. Like, take a 2 tablets of paracetamol or drugs or something that patient think it can, relieve the symptom, some kind of something like that. And the third one is about the part medical history, like a part disease or medical conditions, like some patient may have the medical conditions like diabetic mellitus, like or DM or hypertension or dyslipidemia or kidney disease, something like that. And the fourth one is medication history. The medication history is also important as well because when patient come for doing the procedure, like in the cath lab that need to insert the catheter into the patient, right? So some drug may may stop in some patient. For example, warfarin, that is the anti-thrombotic drug, right? So in case of it, when patient um, have warfarins, like take the warfarins daily on daily or something like that. So it can cause bleeding in the patient because too much anti-thrombotic agents is not good at all. It's like when after it will increase the risk of bleeding to the patients, right? When we insert like when the doctor insert catheter or um, equipment to the artery, right? So in case the tip of the catheter or artery in the wasket that rupture or damage to the artery or coronary artery wall. So in kind of that, so the like there is a less chance to stop the bleeding if the patient have the warfarin, because there is the time of the clotting is less and something like that. And the fifth one is about family history. Like we have to ask about in the family there is other person suffer with disease or some disease that relate to the patients like DM or heart disease or you know something like that. And the social history is also important because we have to ask the patient about smoking and alcohol drinking, because we will if we ask about the smoking, so we can determine or we can uh, assume that's how was of the coronary artery of this patient is, like in like 40% of heavy smoking have the worst coronary artery, like there is a diffuse coronary artery and have a lot of calcify in those heavy smoking patients. And the last one is about the system review about how the functions of the ear, eyes, nose, throat of the patient is, how the renal function is, how the nervous system function is, how the other cardiovascular function is. So you have to ask this thing to the patients to get a lot of information that we need to use this information to plan the procedure. And about the history taking, I have some note that I need to tell you. Like I told you earlier, that there is some point that is unnecessary concerning to the patient in the history taking, like uh, in patient that have the that take warfarin daily. So we need to tell the patient stop the warfarin for 3 days before starting the procedure. Like, in case today the patient have to comes to the hospital, right, and have the procedure. So before this day, like 3 days earlier, we have to call to the patient to stop the warfarins. And some patient that will take the warfarin would be suffer with the deep vein thrombosis or DVT to prevent the clot and also pulmonary embolism, or patient who underwent the mechanical valve implantation, or patient who recently underwent to the valve replacement. So in those patients, we'll have uh, the warfarin taking. So when you see the medical condition of this patient, or when you see the disease as the patient breakout, so patient breakout, so you can look at the OPD card of the patient, that is there any medication that the patient is, so you will find the warfarins on that. And you also must ask about the iodine or seafood allergies in history taking, because in the procedure we use the contrast media, right, to which is the agent that when the X-ray beam pass to the patient, so this agent can, it's just like when inject into the patient, it will use to visualize the structure in our body, like in case we inject the contrast media into the coronary artery, so we're gonna see the structure of the coronary artery when we give or when we generate the X-ray beam pass to the patient at that position. And the contrast media normally contain of the iodine and like base, like con, construct from the iodine base. I'm not sure about that, but anyway, if the patient allergic to the iodine or seafood, so you may concern about the contrast media taking. But anyway, there is other type of the contrast media that use less iodine base in the ingredient, so we may consider that type of contrast media instead of using traditional one. And you have to tell the patient stop taking metformin or glyburide as well for 1 day before start the procedure. So this drug is generally used in a DM patient that's not, like uncontrolled blood sugar, something like that. So because you might wonder that why we have to stop the patient taking metformin or diabetic drugs. So the reason behind this is because before doing the procedure, you can see that patients should be fast at least 6 to 8 hours before starting the procedure. And in some case, if the DM patient that have to doing a CAT or PCI on the procedure in cath lab normally take the metformin and glyburide, right? So in case of this, there is no food or there is no energy exists on our body, but like there is no glucose on our bloodstream, right? But anyway, the drug is also diffuse into our artery and take action to the cell, keep as much as possible of the sugar back into the cell in the DM patient. So in case of this, the patient might feel not better, like feel fatigue, and it might cause another complication in the procedure instead of doing normally procedure. So we have to concern about a metformin or DM drugs taking in the DM patient as well. We have to let the patient stop this drug metformin and glyburine for at least 1 day before start the procedure. And the last one, like I told you, patients should fast at least 6 to 8 hours before start the procedure. Anyway, it's just like the traditional guideline that need the patient fasting before doing the procedure, because in some time when the patient's stomach is full with a lot of food, right? So in case the patient has the aspiration, so it will cause other complication to the patient when like some patient may allergic to the contrast and vomiting a lot, and will cause the aspiration and will generate or will create the worst outcome into the patient. So the patient should fast at least 6 to 8 hours. But in another hand, in the recent guideline or in the recent way, so some interventional cardiologists not prefer to stop eating on the patient, right? Patient have the right to eat food before doing the procedure, right? And the case of aspiration in the patient whose stomach is full, is rare, like not generally found in cath lab. Like it's really less percent of the case where that has aspiration while doing the procedure. So in some hospital or in some interventional cardiologists may not um, prefer the fasting on the patient. And the thing that you need to perform to the patient is about the perform Allen test. Allen test is just the test that will use to examine collateral circulation between radial and artery. Because in some cases in cath lab, so especially the CAD that need to do the CAG or angiogram or PCI percutaneous intervention. In some cases, so the approach side would be the wrist, right, that will insert the sheet or guide wire or catheter through the radial artery. So we have to taste that when we block or when we insert the catheter through the radial artery, the peripheral blood perfusion beneath the radial artery to the thumb and index finger is, normal. Like have the collateral circulations from the ulnar artery. So the Allen test is the best way to examine this. And the indications for doing the Allen test is about the radial artery puncture for arterial blood glass or cardiac categorization via tuned radial approach, like I say earlier, and also radial cannulation on wrist surgery. In this procedure have to test about the collateral circulation between radial and ulnar artery. And normally the Allen test can classify into two classes. The first one is traditional one, which is Allen test, and the second one is the modified Allen test, which have some steps that's slightly different. But anyway, the interpretation is similar between these two types. And here is the schematic that I would like to show you about the circulatory system of the hand from, radial artery and ulnar artery. You will see that these two arteries have the collateral circulation in hands. We call that the palmar arch here, that will, perfuse the blood to our fingers and thumb. So once the radial artery is blocked, so when we perform the Allen test, we will ensure that there is another artery like ulnar artery that will perfuse the peripheral tissue to the hands and thumb, like index finger, something like that. And here is how can we perform the modified Allen test or MAT. First of all, you have to ask the patient to tie the fist for about 30 seconds, like in the left picture as you see. But first of all, you have to palpate the radial artery and ulnar artery first before asking the patient to tie a fist, or I'm not sure about a clench, something like that. And after 30 seconds, so you have to obstruct the blood flow, like place your fingers or your thumb on the radial artery and ulnar artery, like in the middle picture with two fingers at the same time. And after that, you tell the patient to unclench their palms, and you will see the palms look fade, lies not red and warm on the palms, right? Because we occlude the artery that, we occlude the perfusion to the peripheral tissue, right? That peripheral part to the hands or to the finger, right? So you will see the palm is fade, not warm or red at all. And after that, when you put off your finger that compress to the ulnar artery, so you will see the palms of the patient becomes to red within 5 to 15 seconds. This shows the collateral circulation or between ulnar artery and radial artery is good. Like that is good but for. So we can interpret this like negative modify a lentils, like a negative result. There is no problem with the collateral circulation. But in the other hand, if you release the finger that compress on the ulnar artery, and in 5 to 15 minutes, the hands of the patients will look fade, like no red, no warm on the palms of the patient. So in case of this, we can interpret as the positive modified lentils. So in case of this, the radial approach may not consider as the approach side to the patients because the collateral circulations of between radial and ulnar artery may have some problem. And you will see on the right picture when doing the modified lentils, you will see here is the strongly positive results of the lentils. You can see that when we block the radial artery, thumb and index finger, no perfusion at all. You will see there is no sign of red or warm, there is no blood perfusion at all. You will see the face, just the fade palms on this side. And there is another test that will examine about collateral circulation of radial artery and ulnar artery as well. We call that Barbeau test. And the principle of Barbeau test is similar to the, Allen test as well. You can see that, but in terms of we observed with our naked eye, we will use the pulse oximeter. Like I ever give you a lecturing about pulse oximeter, like in the last semester, right? In the hemodynamic monitoring, that the pulse oximeter will measure oxygen saturation and also the pulse rate, right? And in case of the Barbeau test, we also use the pulse oximeter as well to test or examine collateral circulation. You will see that first of all, we will ask the patient to open the palms like in the picture. After that, we will clip the probe of pulse oximeter on thumbs or on fingers because because in this part of peripheral tissue or in this part of peripheral organ is directly perfused by radial artery light, so we can see the different the changing of the pulse wave when we occlude to the radial artery through these fingers like thumbs or index finger. And after that, after you attach or clip the index or thumb of the patient with the probe or pulse oximeter, so you have to use your thumb or finger to compress on the radial artery and ulnar artery. And after that, like in this picture, you will see after we compress on the radial and ulnar artery, the pulse wave of the patient will damp that were detected by this pulse oximeter will damp that show on B. And after that, after you release the finger or thumb that you compress to the ulnar artery off, so you will see the pulse wave return to the normal. In case you see the pulse wave return to the normal, so you can interpret like there is no problem on the peripheral circulation between radial artery and ulnar artery of the patient. But anyway, in this method, there is just, more details about the interpretation. You can see that we can categorize the result of the Babel test into 4 types: A, B, C, and D. For the type A, after you start doing the procedure, right? After you compare the pulse wave before compress both radial artery and ulnar artery, and after you release the pressure after 2 minutes. So when you see the pulse wave return to the normal, like a similar amplitude or same rate of pulse wave, so you can interpret like no damping of the pulse tracing. And in the type B, normally the type A just found just 15% of the patient when doing the Babel test. And for the type B, you will see that when we look at the pulse wave before we compress the pressure on the radial artery and ulnar artery, when we start that, you will see that the pulse wave will damp a little bit, right? And after 2 minutes, after we release the pressure that we take on the radial artery and ulnar artery of the patients, you will see that the amplitude will return back to the same amplitude before we compress the pressure to the artery. So we can interpret like damping or pulse tracing, and normally people generally people like 75% of generally people will have this pattern like in type B. But for type C, when you compress the both radial artery and ulnar artery, you won't see any pulse wave exist or happen on the pulse oximeter. And after 2 minutes after you release your fingers, you will see a little bit pulse wave, like a little bit amplitude of pulse wave show on the pulse oximeter. Here we can interpret that loss of pulse tracing, and just only 5% of the patient have this pattern. And the last one is the D pattern, like there is no pulse wave back after you release the pressure that you place on the patient radial artery and ulnar artery. It accounts at 5% as well. So in case you see the result in terms of type C and D, so the transradial approach may not appropriate to this patient at all, because there is no there is some problem with the peripheral circulation between radial and artery, and those patients who has the Babel test in type C and D may prefer to use the femoral approach instead of transradial approach. And after you perform the Allen test or Babel test, you have to palpate the patient pulse as well to examine that there is something on the, like peripheral vascular problem or not. Like you can palpate the pulse of the patient on the peripheral organ of patient extremity, right brachial artery or radial artery or femoral artery, posterior tibial artery, popliteal or dorsal pelvis artery. But anyway, in some patients, if you don't feel the pulse on the peripheral or on the extremity, you have to palpate the pulse of the patient on the femoral or abdominal aorta, which is the large artery line and is easy way to feel the pulse. In case you don't feel the pulse of the patient on that in this side, you might consider that there is something on the patient like bleeding or shock, just hypotension, something like that. But anyway, if we look at the monitoring always, so I think we might see some change fast later than palpate the pulse. And here is the peripheral pulse assessment, like the grading criteria to give to the position, to give to the patient when we palpate at the exact position. Like, for example, if we palpate the brachial artery lines, if we feel the pulse, like normal pulse, we can grading like grade 3 pulse, three pulse is just normal pulse of the patient. But in case you will feel in case you feel strongly pulse of the patient, hit your fingers, or like you feel like it's very strong pulse of the patient, you can grade like 4 plus. And in other hands, if you palpate the patient brachial artery and you don't feel any pulse, you can grade like 2 plus or 1 pulse. It just depends on your feeling of the patient pulse. But if you not feel the pulse at all, like you ask your friends to palpate the pulse, you ask doctor to palpate the pulse, and everyone consider that there is no pulse at all, so you might give the grading 0 to the brachial artery in terms of peripheral pulse assessment. And there might some problem on the on the brachial artery, like stenosis or occlusion, so patient need to investigate it further on the brachial artery. And for sure, in case you don't feel the pulse on the brachial artery, so you can approach you can use the radial artery as the approach site at all, because there might be stick or stack of the catheter at the brachial artery position. So if you don't feel the patient pulse on the brachial artery, so the femoral artery may consider as the approach site instead of the radial artery or the wrist. And after the nurse asks about history track, or do the history tracking, or perform the Barbu test or Allen test, so now patient is ready to see the cardiologist or doctor for getting the order about the hospital admission before doing the procedure. So in the doctor order, you will see like blood test that the doctor will order some laboratory about BUN, creatinine that is really reflect to directly reflect to the renal system, or electrolyte like sodium, potassium, calcium, or phosphorus, or magnesium, or chloride that reflects to the physiology of the patients, right? If if this electrolyte changing exists, so the patient conditions may be changed. And the FBS of fasting blood sugar is also important, because if the patient has the low blood sugar level, so patient might have some condition like fatigue and have the hypertension, and will increase the risk of unpleasant event while doing the procedure. And the blood count is also important laboratory as well, because we need to know about how good the hematocrit of the patient is. Like if the patient has the sign of anemia, like has the low hematocrit than usual, so we might consider to, give the patient about the uh, blood, or concerned about giving the saline through the IV. And the white blood cell is also important laboratory parameter as well, because we need to look at the patient is sick or not, or have other inflammation or infections or not. So we will see this white blood cell as one parameter um, to evaluate the inflammations or infection. And about INR, or INR is really one important parameter to uh, access the clotting of the patient in case the patient take the warfarin. So normally, like when the patient have to do the cath lab, especially in the CAD, like in the CAG and PCI, so INR should below 2, and normally people not over. I'm not sure about the exact reference value, but I'm normally people not exceed zero point 0.5. I'm not sure about that, but anyway, if patient have to do the procedure, so the INR value would be should below 2. And the cardiologist or doctor will order about the 12 leads ECG to evaluate the electrocardiology. Sorry, about the electrical conductivity of heart. And doctor also order about chest X-ray as well to see how good the lung is. Like there is no unclear film, or there is no sign of the lung infection that might be the cause from the TB or tuberculosis, that is the bacterial infection, right? And it causes as the airborne infections. So if you see that the film shades of the patient unclear, so the doctor may ask further about investigate the sputum or some kind of that to investigate about the TB to prevent or to prevent the healthcare personnel from the infection of the TB. And the doctor will order about clopidogrel as well, is a antiplatelet drug. The reason that the doctor give the clopidogrel in the patient before doing the procedure, because it will reduce the risk of clot formation, right? Because it can inhibit the clot formation. And about the flumoxil or N-acetylcysteine is really, like in some hospital we consider this drug as the traditional drugs that need to give to the patient always before doing the procedure in cath lab when have to use contrast media, because it can reduce the risk of contrast induced nephropathy. But anyway, in some hospital, some cardiologists may consider to give the flumoxil in case the laboratory results of patient has the creatinine or BUN higher than the reference range, like higher than the normal. So the flumoxil will be considered to give to that patient. And about the aspirin is also one of antiplatelet, right? But it has, slightly different action when compared to the clopidogrel. And the aspirin is considered to give to the patient as well before doing the procedure in cath lab. And doctor also ordered about IV line open, because we have to open the patient alveoli always, because in case the patient during the procedure there might be some unpleasant or you know the unexpected situation that can happen to the patient always, like cardiogenic shock, or maybe hypotension, or bradycardia, or some complication that can happen while doing the procedure. And when the interventional cardiologist needs to give the drug to the patient, so they can directly give to the IV line that already opened on the patients, like reduce the time consuming in that room. And the doctor may order about the groin and wrist shaving as well, because like I know that when you insert something into the patient, so the surface around the inserting site you know have to be sterile, right? There is no contamination, have to be sterile 100%. So you have to shave the hair on the groin and wrist area as well to prevent the contamination. And the last one is about informed consent, because informed consent is very important. You have to let the patient sign on in the consent form before doing the procedure always, because it will protect us from some case that had some sue, or some case that the patient will sue us, some kind of that. So we have the consent form about this always to support or back up us always. And in this slide, I would like to tell you about how can we attach the 12-lead EKG, because when the doctor order about the 12-lead EKG, right? So it's gonna come to our role directly. Like our role is, you know, examine the ECG of the patient, right? So you have to ensure that you attach the electrode on the right position and on the right way. So if you look at that, so normally the 12-lead ECG composed of the limb lead, right? Limb lead is composed of lead 1, 2, and 3, and also the unipolar lead, right, which is the AVR, and AVF, and also the chest lead, which is the V1 to V6. So we have to ensure that we attach entire of leads in the right position and the right way. I say it again. You will see that the ECG that like the electrical conduction, or the acid that exists on each electrode can determine what is the problem on the myocardial segment. As you can see, like normally the lead 2, 3, and AVF may refer to the inferior wall. If you see the ST elevation on lead 2, 3, and AVF, so you might assume that the right coronary artery may have the occlusions or something like that. And if you see the ST elevation on chest lead like V1, 2, 3, and 4, so you might consider that there is some occlusions on the LAD or not, so you might assume that from the ECG. But anyway, if you see the ST elevation, so like there is the electrical acid, right? So in like the opposite side of the acid should be have some event that reflect to that. Like in case you see the ST elevation on lead 2, 3, and AVF, so you may see the ST depression on on you know lead AVL, something like that. It's called reciprocal change. But anyway, you will learn about this further about ECG in the next course. I'm not sure about it. It would be a pacemaker or some kind of that. I'm not sure about it. And here in this slide, I would like to show you about the coronary artery territories, and you will see that, I know you already learned about the anatomical of coronary artery and heart structure already, right? In the second years, I'm not sure about that. You can see that the RCA will serve the right side of us, right? Like, right atrium and some left atrium as well, sinus nodes also, and also the a left ventricle that accounts as the inferior part of the heart structure. And another side, you will see the LCA or left coronary artery that have the three bands. The first one is left main. Left main is the greatest part of the left coronary artery, like it very huge diameter and will branching into the left circumflex and also LAD or left anterior descending aorta, which there's two branch, like which two kind of arteries, like left circumflex and also the left anterior descending artery will serve the anterior part, and like will serve the whole left ventricle, like septum, apex, or lateral, or something like that. But anyway, the major role of the LAD or left anterior descending is to serve the septal band and anterior part of the left ventricle. Another case, in other hand, the left circumflex will serve the lateral part of the left ventricle. And here is the electrical axis. I would like to show you about the Ecg attachment. Alright, after you performing the ECG, the doctor will tell the patient about the complication of the CAT or PCI to the patient, because when the patient get the knowledge about doing the procedure, so some patient might feel unrelaxed, like feel straight on, feel uncomfortable to doing the procedure. So the doctor will give the information about the procedure to the patient to release the straight of the patients. Like normally the diagnosis left heart catheterization, the date of the patient just found just 1.1 case per 10,000 case, so it's really a little number of dates in case doing the left heart catheterization. And when you look at the table on the right side, you will see about the procedure related to procedure-related complications of cardiac catheterization, and you will see that the patients when need the patient that do the PCI, you will see that the complications from any adverse event will be at the 4.5 53% that will have the adverse event in the PCI from STEMI as without STEMI. But anyway, from when the patient have to do a PCI, in case the STEMI, so the adverse event might be increased double time, right? Because it's very critical event. And you will see that when we look at just only the diagnosed catheterization, the percentage of adverse event that gonna happen to the patient is really less. It's just like 1.35%. So when you tell this information to the patient, so you can relieve the patient stress and sometimes uncomfortable to the procedure to the patient, you might relax the patient as well. And first anyway, this role may comes to the doctor, but anyway, in some time that patient asks to us about, oh, I'm so scared for doing the procedure, So we have to give this information to the patient, right? Oh, no fear, don't worry about the procedure, it's fine, it's you fine, you're not, the desk it really rare to find in the CAG and PCI. You have to tell this information to the patient if the patient asks you back about their really state while doing the procedure, something like that. And after that, the patient will admit to the CCU, and you will see that the patient will change the clothes according to CCU policy in each hospital and attach the bedside monitor and power oximeter as well. And the nurse at CCU will check about the doctor orders and result that in the IPD chart. You will see the nurse will check or verify about the site of catheter approach or the approach site, like through radial artery or femoral artery, and verify the underlying and other disease, and verified about the lab results or the ECG result. And the drug or fluids administration might be given in the CCU according to the doctor orders, like aspirin or clopidogrel. And the last one, the nurse in ICU have to ensure that the patient already signed in the consent form before doing the procedure. And here is some take note about the protocol for give the NICU testing of flumucil to the patient to prevent the contrast in the nephropathy. So you can, I think you can comprehend this by yourself. Here is the example of pre-procedural checklist for cardiac categorization. You will see is very, a lot document that you have to concern about that. In some hospital, is really quite a lot of work to do. But anyway, to ensure that we do the right procedure on the right patient, so we have to do this checklist always. And when patient arrive to the preparation area in cath lab, like patient come from the CCU, so when we are the cardiovascular technologists in the cath lab, and when we receive the patient right in the preparation area, so we have to verify the patient right, like there is the right patient. You will see the name of the patient on the IPD chart. You see the disease and also hospital number, something like that. After that, you have to ask the patient about symptoms now on the patient in case the patient suffer with the CAD or coronary artery disease. You have to ask about chest pain, and if the patient say like yes, I have said like yes, I have a chest pain, so you have to ask about the pain score to the patient as well, from 1 to 10. The 10 of pain score is really pain, like pain a lot, and the 0 is no pain, 1 is less pain, something like that. You have to notify, you have to mark the pain score on the chart as well. If the patient tell you about he or she has the chest pain. And you have to check the patient chart as well, the consent form, IV site, that the nurse open the IV site in the appropriate arms, like some, I think it's just depend on some hospital. Like in my experience in my hospital that I ever worked before, doctor may orders the IV line, order to open the IV line on the left arm of the patient instead of the right arm, because it will, if you have to see if the patient have the IV line opening on the brachial on the wrist, so it might disturb the approach side when doing the procedure, right? Like we have to insert the catheter to the right radial artery, so it may interrupt the step of the interventional cardiologist. And you have to give a brief information of procedure to the patient as well, like the size of the catheter approach, like we will insert the catheter through your wrist, or we will insert the catheter through your groin or something like that. So we have to give the information to the patient always, and we have to tell the patient about the symptoms that you have to, that the patient need to warn healthcare personnel surrounding them while doing the procedure if they have that problem, like in case the CAD again, why the coronary artery is occluded by balloon catheter. When doctor inflate the balloon, the patient should warn the doctor about chest pain, because you see that when we inflate the balloon, right, so it will occlude the coronary artery 100%. So in the long period of the balloon inflations might cause the patient uncomfortable and feel chest pain. So you have to tell that if patient feel more chest pain, have to warn the doctor about that. And the last one is you must tell the patient about the risks, and meanwhile you must relieve the patient's stress too. Like I tell you, every procedure has the risks, right? But anyway, you have to give the way that can release the stress of the patient too. And after the patient comes from the preparation area into the room, you have to transfer the patient to the X-ray table, as you can see in the first slide. I show you that on that table, and attach the ECG as well. But anyway, it's not just 12 lead ECG at all that need to attach on the patient, just only the limb lead, which has the RA. RA is stand for right arm, right? And LA is stand for left arm, and also LL, left limb. Just attach 3 of this. And in some cases, so the oxygen cannula may be given in case the oxygen saturation of the patient below 95%. So the oxygen may be provide or give to the patient. Normally begin at 3 to 4 liter per minute. And in STEMI case or ST elevation myocardial infarction case, the electrode pad of defibrillation may be secure attached on the patient as well, because in case of the emergency, like you see, like in case of the STEMI, the VT or VF is generally found in the patients, and if you attach the electrode pad on the patient, you can don't touch on the steroid field, and you have to redo the dapping on the patient, and it's really time consuming. So if you attach the electrode pad on the patient before start doing the procedure, so you might short talk always when you see the VT and VF on the patient. But anyway, you have to follow the doctor order, right? Not don't have the right to hit the chart shop by yourself. And the scalp and circulate technician or nurse should tell every step to the patient in terms of preparation on the table. Like if you are a scalp technician and you prepare the patient, like draping the patient or something like that, you have to tell every step that you are doing to the patient to them, because patient is not unconscious in this room. The patient is awake always when doing the procedure in cath lab. It's different from OR. There is no Like there is no general anesthesia at all. It's just like local anesthesia that give some lidocaine to relieve the pain at the puncture site. That's it. There is no general anesthesia at all. So patient will awake entire procedure, and you will have the interaction to the patient, and also the doctor will have the interaction to the patient as well. And before start doing the procedure, you have to nurse or we or anyone in the room that have the health that we healthcare professional should always perform time out before start doing the procedure, because like I told you earlier that we have to ensure that we do the procedure in the right patient, the right procedure, and we have to ensure about that. And here is the I'm sorry. Oh, and here is some video clip that show you about how can we prepare patient in the cath lab. It's very a short clip. We will see that at the ICU, doctor will tell about the risks to the patient, right? And here is the patient comes from the CCU to the cath lab. So you can hear my voice or just video clip voice. I'm not sure about that. And here is if we are scalp technician, we will prepare the site of the puncture. In case of this, the patient will doing the procedure through the radial artery. And here is the scalp technician will drape the patient to make a sterile area for doing the procedure. In case of it, you may see that the open IV line exists on the right arm of the patient, right? But in some hospital may not prefer this position of the IV line. And here is the doctor will puncture to the radial artery. You see that the sheet will insert into the patient now. You see that the patient awakens entire procedure. Okay. And here is the example of the timeout procedural checklist. You have to, you have to speak out in the room loudly about the patient names and medical record number, about the procedure to be performed, like left heart categorization or CAT or PCI, and you have to speak out to confirm that the equipment that important to that is available in this room. Like you have to tell about PCI, W2 balloon, and there's some kind of like the plan of procedure. And you have to speak about the patient's allergy and laboratory or medical conditions and the consent form as well that already signed by the patient. So you have to speak out loudly to let everyone in the room, also the patient and also the hemodynamic monitoring technician in the monitoring room can hear about the patient information. And this is the event that we call timeout. We have to do before doing the procedure in every case. And why doing the procedure about the perioperative care? So you should keep the patient safe from ionizing radiation exposure. Like in case of this, we're not, we're not authority to concern about this, but anyway the doctor will concerned about the ionizing radiation exposure, like must to give less x-ray exposure to the patient, like use just less x-ray energy to get the image, something like that. So normally patient must expose to the radiations less than 5 grays. But anyway, we have to we have we have the protection, right? Before we come into the procedural room, we have to wear a thyroid shield, right? Goggles, and also the lead apron, something like that, always to protect us from ionizing radiation exposure. And like in the, the first day in this course that Hosunchi already tell us about Alala, that Alala is like the guideline to protect us from the radiation exposure, like keep long distance, or protect by wearing the lead apron or shield, and use the less radiation exposure, something like that. And if the patient get much get a strong exposure to radiation or X-ray beam, patient have to be followed up and calculate peak skin dose in case the patient exposed to X-ray more than 10 grays. As you can see in this picture is the back of the patient that exposed to the radiation over than 10 grays. You will see the erythema on the patient screen. And while doing the procedure, you have to concern about contrast volume as well. In case normally people like don't have the CKD or chronic kidney disease or renal failure at all, so patient shouldn't receive contrast over the threshold. But anyway, there is many many criteria of the contrast threshold out there, but normally the threshold slightly similar. For example, in normally people, so the GFR is glomerulus filtrate rate light, is the rate that may show about how the rate of the kidney filtrate the blood is something like filtrates, like the waste is something like that. So normally people with the normal kidney functions, the GFR is about 90 or 100%, something like that. So normally people will get the contrast media if the patients had no sign of the kidney disease, like has the better GFR. So like 90, we say that 90%, something like that. All right, so you will assume that the maximum contrast media that we can give to the patient while doing the CAG and PCI is about not over 180 milliliter. When you see from this criteria from GERM and et al. This, and if you look at this criteria, so the maximum contrast volume that you can give to the patient if the patient has the normal kidney functions, just like about the not over the 300 milliliter, about that, like 300 to 400. And you will see that if the patient suffer with some chronic kidney disease or have the low GFR, so you might consider the maximum contrast volume by using the GFR ratio, like GFR ratio or something like that, by using this equation. Yeah, and the ACT should be checked as well while doing the procedure after 1 hour after the initial dose was so the initial dose is giving. Like normally when the patient doing the CAG, the heparin won't administrate at all. Like it's just a short duration, right? During a CAG may take like 15 to 20 minutes about in terms of the CAG. So the procedural time is really short duration. So the heparin might not consider in that case. But in case the patient have to do a PCI, is really long durations for doing PCI, at least 1 hours or 2 hours. But anyway, not I'm in my experience, I'm not seeing the case of PCI take time over than 4 hours. But anyway, in every hour you have to check about the activated clotting time. And the activated clotting time should be over 200 seconds prior to perform the PCI or percutaneous coronary artery intervention. In case the ACT below this 200 seconds, so you might be considered to give the heparin again, but in the half dose of the initial dose. It just depends on the case, like it just depends on the case duration as well. Like, if we're doing a PCI for 1 hour, but just a 10 minutes the case will finish. So the doctor might not consider to give the heparin at all, because when we give the heparin, right, it affects to the clot formation right after we withdraw any equipment from the patients and we have to stop the bleeding. It's really hard to stop because we already gave the heparin to the patient. So we have to consider about the duration of the procedure as well when we decide to give the heparin. In some case of the CAD with proximal RCA lesion, some case, like I told you at the RCA, there is a branches that perfuses to the SA node, right? And if there is the lesion on the RCA, and the patient might feel vomiting, something like that, while doing the procedure, when we have to inflate balloon a lot on the proximal RCA, because just you will see on the screen that the heart rate of the patients might slower, and you will see the bradycardia as well. So in case of it, because the SA node lack of sufficient perfusions from the sinus from the SA node artery that is branching from the right coronary artery, and you have to concern about that. So you have to prepare the bag to clean the patient things that come out from vomiting, something like that. And thank you for your attention. It's quite a long time for lecturing about this topic. All right, so do you have any question? หลับไปหรือยังยังไม่หลับใช่ไหมยังอยู่ค่ะอ๋อยังอยู่นะโอเคอาจารย์ค่ะครับข้อคือออกตามสไลด์ที่สอนเลยใช่ไหมคะใช่ครับแล้วก็จะมีบางอันที่อาจารย์พูดไปบ้างแต่ไม่เยอะขอบคุณค่ะครับไม่มีคำถามเนาะโอเคแล้วเดี๋ยว case study อะครับเดี๋ยวอาจารย์น่าจะอัปโหลดใน TU Moodle อะน่าจะวันไม่เย็นนี้ก็พรุ่งนี้เช้าแล้วเราก็ลองไปทำ slide presentation เอาแล้วก็เดี๋ยวอาจารย์จะอัปโหลดเป็นตัวเคสแล้วก็ evaluation criteria ให้ด้วยก็ลองไปประเมินกันแล้วก็มี3คนนะครับยังไม่ได้ลงใน Google Form ว่าจะไปบริษัทเนี่ยไปดูงานบริษัทเทอร์โมเนี่ยจะไปกับอาจารย์หรือว่าจะไปเองอย่างเงี้ยมีอยู่3คนอาจารย์รบกวนลงให้ด้วยนะเพราะอาจารย์จะได้ทำเรื่องแบบขอรถตู้จากคณะไปเนาะ โอเคไม่มีอะไรแล้วใช่ไหมครับ
อาจารย์คะหนูถามนิดนึงได้ไหมคะไอสไลด์ coronary artery territories อะค่ะที่เป็นหน้า18อะค่ะที่อาจารย์พูดเกินเนื้อหาที่ว่าเส้นนี้ทำอะไรบ้างนี่ต้องจำไหมอะค่ะ
อ๋อไม่ต้องครับไม่ต้อง
เห็นมันลึกมากเลย
อ๋
พ
อ
อ
มัน
ดี
ลึก
ไม่มี
มาก
ใน
ใช่
ส
ไหม
ไลด์ด้วย
โอเคไม่ต้องจำครับ
ขอบคุณค่ะ
ครับ โอเคงั้นก็รีบได้เลยครับ
ขอบคุณค่ะอาจารย์
ขอบคุณค่ะอาจารย์
ขอบคุณค่ะ
ขอบคุณค่ะ
ครับ